and I am lucky enough, I actually have a question before I even start. Vivian, can you just read it out for me?
Yeah, absolutely. So the question is around how soon CMS will be releasing CQL queries with FHIR resources rather than QDM. And in the interim, how do you suggest they convert from QDM to FHIR?
All right. So there are measures, FHIR-based measures based on the original CQL, or excuse me, QDM-based CMS measures that are available on the Connectathon repository. The best way to find those, and I'm sure I can post a link after the talk, but if you go to the HL7 Confluence and look for the clinical reasoning track, there's links back to those resources. If you're asking about an official date, that's something you'd have to ask CMS. I am in no way qualified to answer that question. And for the second part of your question about mapping, the QI Core implementation guide provides within it mappings from QDM to QI Core. So QI Core, for those folks, and I'll get into this in a little bit, is an implementation guide that sits on top of US Core that includes the extra data that's needed to report quality measures. All the elements in there should have mappings back to QDM where applicable. All right, so screen over again. I think I've already been introduced, so in the interest of time, I'm just going to skip through here. So today we're going to talk a little bit about querying for and submitting quality measured data. And how that improves over the current process of using QRDA and QDM-based measures. We're going to talk a little bit about how we can use FHIR to reduce reporting burden for both vendors and providers. And then in the second, I guess it's more the second 2/3, we're going to talk about the gaps in care work that has been going on under the DaVinci DEQM gaps in care use case. And if you were in Viet's talk Friday, or excuse me, yesterday, you probably heard a little bit about that. So we're going to do a deep dive into that and take a look at what a care gap report looks like and how to create one. So the DEQM has been around for quite a while. It started in 2018, focused on medication reconciliation. I believe the second version is a new STU could be published any day now with the gaps in care information. Which should be out at any day now. So this is a diagram of the standards evolution. So on the left, you can see what we have now, and on the right, you can see where we're going. And
Sam, I apologize. I can't see your screen. That might just be a me thing, but I just want to double check that you are indeed sharing your screen.
Okay, and I lost my screen share. How's that?
There we go. Now you're all set.
All right. So over on the left here, you have the existing technology stack, QRDA, QDM, and CQL. On the right, we continue to use CQL. We just use it with a different data model. And what that data model is based on the QI Core profiles. And going to that, replacing HQMF, we have the quality measure ID, which describes the various components of each of the quality measures. And then down below here for the actual reporting, we replaced QRDA with the FHIR measure report resource, which is profiled in the DEQM implementation guide. And we can support both the QRDA 3 style population reports and the QRDA 1 patient level data reports using the DEQM measure report types. So here's your first glimpse at a, well, for some of you at least, for a FHIR-based measure. You can see it actually looks a lot like a QDM measure, at least this part. This isn't all of the measure, but we still have, for most measures, we have the numerator, the denominator, denominator exclusions, IPP, et cetera, and we're looking for specific data elements in a patient record. So for this measure, which is based around colorectal cancer screening, we are looking for a colonoscopy or other equivalent clinical data elements. And we can also be excluded if there's the patient is in hospice, and we're looking at patients that are between the ages of 50 and 75. So we'll start with how we're actually structuring the measures in FHIR. So we use the group type to denote the different populations of a measure. So like I said, you can see here the IPP, the denominator, the numerator. But we're going to focus on the, for most of this talk, we're going to focus on the library and the data requirements parts of the measure. So a library, which represents a knowledge artifact, will have a set of data requirements, and each of those data requirements will describe something about a piece of data that we're interested in for a measure. So the data requirement type is really at the heart of a lot of what we're doing. You can describe things like, I want to find something, to give an example over here, I want to find a procedure that has a certain code or has a code that belongs to a certain value set. Or I want to find a procedure that has happened within the last 10 years. And there's an operation that exists on a measure resource that you can execute, which is naturally called data requirements, which will return the data requirements in a bundle for you so that you can determine what the data is that the measure is actually looking for and that you need to report in order to qualify for the measure. One of the things we've been working on as a part of our work and as a part of the DEQM use case is introducing a new kind of filter. So I mentioned the code and date-based filters before. We want to introduce this new sort of wildcard filter for the additional types that we might have an interest in. And we base this on mostly on what you can find in a FHIR observation. So if you want to look for something like a quantity, so if a measure has we're looking for a certain percentage of HbA1c in the diabetes measure. We're looking for a quantity of 9%. We're looking for a range that is below 9%. I don't remember exactly which the values that is, but we want to be able to support all these different data types in order to be specific as possible about what the measure is going to require from the patient record. And as it noted, we're proposing that for R5 as an addition, and we plan to add that as an extension to the quality measure IG, so it's available for folks to use when they are querying for data requirements. So to show how this works, we've got this diagram here. You have a knowledge repository over here. This could be a receiving system that you would have at a payer, or it could be separate from that. It's basically anywhere you would find a measure. And so you query for the data requirements, which returns that library. You can then look through that library, pull out the data requirements, and construct queries from it. So here I have an example. We can use the code inquiry to find all the codes that exist within this value set. I think this is the code. This is the colonoscopy value set. And we're also looking for a specific perform date. So for procedure, we're looking for something that is greater than, has to be within the, basically this is within the last 10 years. And so we can query the EHR for that, and we can pull it back out. And now there's a lot of, in production, there's a lot more that goes around this. You would likely need something like asynchronous or bulk data support, but for the purposes of this demonstration, we'll just talk about sort of, pulling out smaller amounts of data at a time. And you can see here with these tables how that sort of maps between data requirements and turning that into a query. And there's lots of different ways you can do it. That's part of what we do at Connectathons is, experimenting with how we can get data out of EHRs. And one of our goals is to not add too much extra burden onto EHR vendors with, a lot of queries or extra work or interfaces that need to be done beyond what already exists. So we're really trying to, find all the data that we need and no more, but with providing the lowest amount of burden possible. So once you've collected that data, so let's say you run a set of queries, you collect all the data you need, you have your list of patients, their procedures, and any other data that's required by the measures. You can then report that using the submit data operation on Measure, which you can report. We have seen folks using the X-Provenance helper that was used in a pilot with CMS a while ago, basically to report information about who is actually sending the data over. And then naturally, of course, you need some sort of auth token to make sure that you are who you say you are, and the person who's reporting the data. And so what you're sending with this is, it's really a set of FHIR parameters, but what you really care about in there is the measure report, which is kind of like a manifest for the data that's coming in, and then the list of resources that are relevant to the measure. And if you're successful with that, you'll get a 200. And there are other ways of doing this transaction. And I think when I did a talk about 2 years ago at FHIR Dev Days, I went into a little more detail on the other ones. There's also collect data, where you would actually reverse this flow to pull the data out of the EHR. And we've also done, there's been some exploration on subscriptions, which I'm hoping at some point we'll get back to now that subscriptions have matured over the last several years. But we'll just focus on this. This is kind of the pattern you would see if you're, a provider that's reporting to a payer. And likewise, there's a measure calculation you can do using a measure. So, over here at the payer side, we can now allow you to calculate your measures on the fly. So as you submit data, you can sort of do this ongoing process where you can actually do quality measurement rather than it having to be this, end of year scramble where you're trying to gather all your data and send it. We want to make it, this more agile, ongoing process, and hopefully, actually lead to quality improvement and not just be quality measurement. And these are the sort of the different measure report types that you can have it spit out. I won't go to those with more detail, but you can look at the spec for those. So for the rest of the talk, we'll be focusing mostly on the gaps in care work that my team at MITRE has been doing. We do that as a part of the Da Vinci Gaps in Care group, but we also have some stuff that is unique to our implementation of this spec. So gaps in care is about reporting back to providers where there are care gaps. So where are they not meeting the criteria for a measure? And in a lot of cases, that means they have patients that are in the denominator but not in the numerator. You have a patient, to use the previous measure example, that we can't find a colonoscopy for within the last 10 years. So that would be considered a care gap. And that basically sends you back a bundle with measure reports for each of the patients that you're looking at, information about the patient, and the detected issue resource, which is the way to signal that there's an issue that needs to be addressed. And so, as I mentioned, we're trying to create this cycle of that actually allows you to improve quality, where you can do these submit data operations, and you can either evaluate measure and get your scores, or you can run care gaps and find out where you still need to make improvements. And so that's pretty standard for how the care gap stuff works. The work that's unique to what the team here at MITRE has been doing is what we like to call detailed care gaps. So while the existing spec that is coming out allows you to say things like, this patient has a care gap, we've been looking into ways to give more detail to providers. So instead of saying, you know, this patient isn't in the numerator, we can say this patient did not have a colonoscopy that we could find that matched this criteria. And we previewed this at previous Connectathons. We got a lot of great feedback. And a lot of that feedback was, no, we want more detail than that even. And so then it became, you know, can we tell them this patient is overdue for colonoscopy because their last colonoscopy was 12 years ago? And a lot of our work over the last several months has been on getting to this level of detail, which is, I think the team that has been implementing this with me would agree is not easy, especially some of the measures have logic that introduces really difficult edge cases. And I'll go through a couple of those real quick. And we've worked real closely with the measure developers to sort of find these and identify these use cases. So the first one, and I'll try to get through these fairly quickly so we have time for a demo later. CMS 122, this was the diabetes measure that I mentioned earlier. This is what's called a negative improvement notation measure, where being in the numerator is a bad thing. You don't want to be in the numerator for this measure. So in this case, it basically means your HbA1c levels are out of control, you know, which for a diabetic is not good. And it also has multiple paths to getting in the numerator, which are sort of exclusive to each other, where either you don't have a test, or you have a test with no listed result, or you have a test and you have a bad result. And we want to be able to tell a provider which one of these is actually causing the problem. We don't just want to say there's some issue with the HbA1c value set, because that's not really useful to a provider. CMS 124, which is breast cancer screening, excuse me, cervical cancer screening. We have to include patient characteristics. So with this one, we have to consider both gender and age. So, you know, there's different criteria here that we might cite in terms of where the care gap is, depending on what the age of the patient is. So in this case, you know, the HPV test for when they're over the age of 30, or, you know, the cervical cytology for other folks. So this is something we're going to have to consider as we create these detailed care gap reports. And then there could be multiple ways to close a gap. So to go back to the colonoscopy measure, you know, there's multiple different things they can do to do a colorectal cancer screening. And we don't want to tell a provider, here's all the things that you need to do, when they only really need to do one of them. And last example of sort of a complex use case is this CMS 506 measure, which is about opioids use on discharge, where we need to count the number of elements. So, you know, if there are more than 2 opioids being prescribed at discharge, then it triggers this, this clause. And so we need to be able to consider the count of things that are happening. So in starting this was, it was one of the I think the most interesting sort of explorations into FHIR that I've had the privilege of doing. And we started by looking at detected, and we noticed that can folks still hear me?
Yep, Sam, we can still hear you.
Detail element, which in the description says, well, why don't you try either a guidance response or a measure report? So we then turn to guidance response. And guidance response was really the perfect element for describing this level of information. So we've got a reason, you know, and it's up to us really to create a code set for this. But, you know, what is the code to represent the reason why something isn't happening? And so what we've come up with so far with our own list is, you know, was an element missing? Was it present? This is something you would see in those negative improvement notation measures. Was the value just invalid or something out of range? And lastly, it's got the data requirements. You know, we can show those data requirements that we're looking for in order to show you, this is where the care gap is, and this is why there is a gap.
And Sam, you actually have a question about some of this functionality if you want to take it now.
Sure.
So the question is, how about, like, I'm assuming they're asking, can you do patient had a colonoscopy in the last 10 years, but they haven't had a visit this year. Can you schedule them for a visit?
Schedule them for a visit. Let me think about that. I think we could do that. It depends on how you could execute the service. And this is one of the things that we've talked about as a group on the DEQM use case is figuring out when a gap is closable. And I think this sounds like it's related to that, where we can find something that is we might be able to close by the end of the year, but is currently open right now. But I'd have to go back and look at our implementation to see how we can handle that. Is that the only question?
That is, and just to let you know, you can actually go back later and answer questions if you go back into the app. So I encourage folks to go look at the Q&A post this as well.
All right. And so we've to go back to the reason code. So this is good information, but we also want to be able to provide that sort of more detailed level of information. And so we're proposing adding an extension called reason detail that would describe something like, this is the actual attribute in question, and this is why there's a gap. So for that colonoscopy, we could say, it's the perform date that is a problem, and the reason would be that the date is out of range. And so that sort of gives us the level of detail that we're looking for with providers. So I'm going to go through some of the sort of solutions to some of the issues that we found. And the first one I'll talk about is group gaps. So this goes back to the sort of multiple paths through a measure where you have multiple ways to close things. And there could also be, a case where you need to do multiple things in order to close a gap. And so we call these and gaps and or gaps. I think that's pretty straightforward. And so the way we've structured how this data would appear in a bundle basically is a detected issue basically represents a gap. That's how it works in the sort of non-detailed implementation guide. And then a guidance response is how a way you can close that gap. So for the colonoscopy measure, you would have or the cancer screening measure, you would have the colonoscopy or the fecal blood occult test, and those would each have their own guidance response. And then for we would have multiple detected issues, and you have to address each of these detected issues in order to actually close the gap. And these can sort of all get mixed together into where you can have ands and ors. So like you could do one thing to close the gap, or there's another case where you need to do two things. We haven't actually found a measure that where that's the case yet, but we're just trying to be prepared. So as I mentioned, you have your bundle. So now in addition to what would normally be in the gaps in care report, we also have the set of guidance responses in the bundle that is returned to you. All right, and I'm going to go switch over to a quick demo just to show what this looks like. How much time do I have left?
You have 20 minutes left.
Okay. All right, so this is a demo that we've set up of our gaps in care service. This is actually running in the browser. We've written this in TypeScript. It uses, so it runs in browser and as a service. It's open source, it's on GitHub. If folks are interested, I can show you, I can send you a link to the repository afterwards. But here I'll just launch into a quick demo. So we're pulling these out of the Connectathon repository of measures that I mentioned at the beginning of the talk. I'm going to look at a denominator measure, since that is a patient that would have a care gap. And first, I'm just going to show you, I'm going to move my screen here. Just sort of what the raw results look like within RAPS. This is going to be FHIR necessarily, but we also support sort of the lower level information that we actually get out of the measure logic that we use for debugging and such. So we can also spit this out as HTML, and we can put this into FHIR narrative. If folks who are listening have used the Bonnie tool, this may look very familiar to you. This is basically measure logic, and we're showing where there are hits and misses in the measure logic. So you can see this patient is hitting the denominator. And they are in the IPP, but they're not getting through to the numerator here. So this is good for visual debugging for someone who might have patient data and want to know why they're not closing a gap when they think they should be. So there could be some sort of data mapping issue. So we also try and serve that purpose in addition to being useful for providers and providing that kind of information that a provider might want. All right, so let me recalculate here using the gaps in care service. All right, so we'll go through the entries here, and let me increase my screen size just to make sure folks can read. All right. So this is the composition. You can see here the detected issue, which contains a number of guidance responses. And here we return a code filter related to the procedure in question, the colonoscopy. And the reason is no data element found from value sets. So that's saying that we can't find anything with this code in the set of patient data. We haven't implemented the reason detail yet. That is next up on our docket for this summer. So I don't have an example of that, but we do have the other sort of more detailed stuff. I'm gonna try and find one of these patients I believe has a date code. I think. All right. Well, I guess this one's might be all code filters. I'm gonna have to dig through all these. But basically, we return the data requirement with the information. So this would, if it was, related to the date of the colonoscopy, we could say, patient has a code filter, or it would have a date filter, and then with the period information where describing, the period we're looking at. So we want to look at this within the next 10 years. Okay, so that's the demo. I'm going to switch back over to the presentation. Unless there's any questions on the demo before I go do that, type them in now.
I think the only question, it wasn't quite a question, more just a comment, is if at some point you would be able to post links to any of the repos used, that would be helpful for folks.
Sure. Yeah, I can, like I said, I can post a link to our repository and also to the relevant repos after the talk is over. All right, so we still have a lot of work to do on this effort. So as I mentioned, there's a version of gaps in care coming out in the next couple of days. This will not be included in that, other than allowing for a guidance response in the detected issue. So the work we're doing is to drive a new profile around guidance response for the next version of the DEQM implementation guide, supporting this detailed care gap use case. And so for us, our next steps, figuring out how to represent care gaps for a continuous variable measure. So for a continuous variable measure, something like average discharge time for an emergency department, where there's like a single value that you're looking at rather than like a numerator denominator fraction. And then episode of care measures, where you're looking at things that happen during an actual encounter with the physician. Negative improvement notation. The measure that I mentioned, the HbA1c control measure for diabetes, that's actually one that I don't believe it's been converted yet, or if it has, it has been done fairly recently. So we haven't tried that one out, but that's really a hits all of the complex, difficult use cases that we're looking at. And so I look forward to when we try and run that through our gaps in care service to see what happens. As I mentioned, how can we determine if a gap is closable? There could be cases where, you know, once a gap is opened, you can't close it. You know, there's nothing really that you can do for that patient to close the gap. And determining that is going to be is something that has been discussed a little bit at the DEQM use case. And if folks are interested in that discussion, please join future versions of that, and I'm sure it'll be an ongoing conversation. And then next up, what we call what are called selective data requirements. So I mentioned earlier talking about how we want to query in EHR to pull data out of it. A selective data requirement would be a data requirement we can use to filter out data that we're not, or patients that we're not interested in, or, you know, one of these like cancer screening measures. So to mark something as selective would be to say, like, I only want the patients that are between the age of 50 to 75. And that way we're not querying every single patient for, you know, everyone who's ever had for a colonoscopy. And we're, you know, still trying to figure out exactly what a selective data requirement is. You know, I think the example I gave is probably a little simplistic, but again, that's one of those ongoing conversations we'll continue to have on the DEQM user group. All right, so to recap what we talked about, the differences between the existing quality reporting standards, which, I mean, the biggest difference is they're not FHIR-based, and these new ones are FHIR-based. Continuing to use CQL, but transitioning to use FHIR-based implementation guides like DEQM, Quality Measure IG, and QI4. How we can reduce burden for vendors and providers. So I touched on this a little bit. I guess I can explain it a little more here. A lot of this work is around aligning the data that we use for quality reporting to the data that is used and can be collected in clinical care, you know, that you would already be mapping to FHIR. So no longer would you have to map to QDM. You can just map those any extra data elements that are used in quality reporting, which, you know, we think will be you know, a lot easier than, you know, doing QDM mapping from scratch for each measure. And for providers, you know, this gaps in care work and being able to do this ongoing kind of agile process, so that, you know, this actually becomes a tool for clinical care rather than just, you know, an exercise in filling out your taxes so that you can, you're not penalized or anything. Demonstrate the steps required to report quality data. I reviewed how the submit data operation works and how you can use that along with both evaluate, measure, and care gaps to do that reporting cycle. And lastly, you know, what a detailed care gap looks like and what that is going to look like in future versions of DEQM. So here's my speaker information, but as I said, I encourage everyone who, you know, has an interest in this stuff. It's amazing how much it has matured over the last, you know, year or two, you know, from where we've come from. into the implementation guides that we have now. So please join us Thursdays from 2 to 3 at the DEQM user group, and also at the Fridays are the clinical quality information working group from 1 to 3. That's where a lot of this information is hashed out and discussed. And the clinical reasoning and gaps in care tracks at the Connect-a-thons, you'll always find us participating there along with lots of other folks. And we're happy to, you know, test alongside and other systems and, you know, try out new stuff.
Awesome job, Sam. You do have one question.
Okay.
Just regarding the guidance response resource, are you creating a separate guidance response resource for each patient in the population with a care gap?
Sort of. Let me just scroll back real quick. So a guidance response is tied to a particular patient, in the sense that it is showing how to close a gap for a patient. But you could have multiple guidance responses for a single patient if there are multiple ways to close a gap. I hope that answered the question. If the person has a follow-up, they can unmute and ask.
Yeah, I'll go ahead and see if I can't let participants unmute themselves. If anyone has any questions, feel free to write it in the chat or unmute, or let you know, email Sam and reach out. Awesome. Well, I don't think we have any other questions. Sam, great job. Really, really awesome job. And thank y'all for coming to this. And I hope you guys have a great, fabulous rest of your dev days.
Thank you, everyone.